Thanks again, everybody, for joining. We really appreciate you coming on today to learn a little bit more about supporting your fertility journey. We're really excited for the collaboration with Ovia Health, Boston IVF, and CDPHP to bring you some education around just your cycle, reproductive health, trying to conceive, fertility treatments, and all those things that come with building a family. Again, just a couple reminders before we get started. Know that you will be muted, but if you do have any questions or comments, please drop them in the chat throughout, and we'll make sure to get to your questions at the end. Also note that the session will be recorded and will be emailed to everyone afterwards. And then keep an eye out for a post-evaluation survey after the seminar today. That'll be sent to you as soon as you close out of the Zoom. So my name is Emily Holteen. I am the Director of Health Plan Solutions here at Ovia Health. I'll introduce our main speakers here in a second, but just wanted to go through what we'll talk about today. We are so excited to be part of the conversation. We're going to talk about just understanding your cycle, reproductive health, and then getting into trying to conceive, understand your fertile windows, and different pathways to parenting. We'll also give you some resources through Ovia, Boston IVF, and CDPHP that can help you with whatever your parenthood journey may be. So again, we're really here to help support you throughout that journey. We know that engaging you through all different reproductive stages is important, and it starts with education. So understanding, where you're at in your cycle, understanding your own body, understanding your fertile windows, and those kinds of things are not always something that is easy to understand. And we also know that your unique health journey is unique to you. So not everybody has the same journey when it comes to becoming a parent. And so we're here to help support that journey. Ovia will talk about throughout this. Ovia has support in-app to help you track your cycles, understand your fertile windows. Maybe you're tracking birth control and understanding contraceptive usage. So no matter where you're at in your cycle, being able to support that entire journey. I'm going to introduce our speakers today. We've got two wonderful speakers, one from Boston IVF and one from our care team at Ovia Health. So we have Dr. Elguero from Boston IVF and Christine Peter from Ovia Health. I'll let them give a little bit more of an introduction of who they are and what their clinical expertise are. So I'll turn it over to Dr. Elguero, and then Christine, maybe you can introduce yourself afterwards and dive into the presentation. Thank you again, everyone.
Thank you, Emily. Hi, and good afternoon, everyone. My name is Sonia Elguero. I'm one of the reproductive endocrinologist and infertility specialist at Boston IVF, and I also serve as the local medical director for Boston IVF here in Albany, New York. We're actually located in Loudonville, and I would like to thank Ovia Health and CDPHP for inviting me here today.
My name is Christine Peter. I'm a health coach with Ovia. I'm a nurse of 14 years. Most of my experience is in women's health, primarily labor and delivery, and also in fertility care. I'm also a previous egg donor and gestational carrier. So fertility is a topic that's near and dear to my heart. I'm really passionate about helping people build their families, however that looks to them. We'll go ahead and dive right into the content here. We're going to talk about trying to conceive and talk about fertility in general. So in trying to conceive, cycle tracking is something that's really important, and it helps to give a lot of basic information. We spend a lot of our early years, learning how to avoid pregnancy. And then when it comes time to conceive, often there's misinformation or, just a lack of general information on the fertile window when we can conceive. So we're going to talk a little bit more about that today. So on average, a 28-day cycle is considered an average cycle length. However, that can vary. Anything between 21 to 35 days is considered a normal cycle, or average or normal cycle length. Outside of that, there's a little variation as well. And when we talk about cycle length, we're talking about the time between the first day of your full flow menstrual period to the first day of your next. So a lot of times when you ask people about their cycle length, they say, oh, it's 5 days or 4 days. And that's not really what we're getting at. We're asking, the length of their entire cycle. So a great way to get started with preparing for pregnancy and preparing to conceive is to start tracking that, because that gives us a lot of information about when your fertile window might be. About half of pregnancies in the US are unplanned or unintended. So even if you're not at a point yet where you're cycle tracking, or if that's on your radar, there's some things that you can do health-wise to prepare your body. Like I said, about half are unintended, and half of pregnant people aren't taking the recommended prenatal vitamins before trying to conceive. And this is really important because certain nutrients, in particular folic acid, can help to prevent certain kinds of birth defects, specifically neural tube defects. It's a folate or folic acid. It's a nutrient that helps to build healthy new cells and helps to prevent these birth defects. And it's really important to start that prior to trying to conceive. So we recommend everybody of reproductive age take a prenatal vitamin that contains at least 400 micrograms of folic acid a day, or folate. And this is a great way to prepare, in addition to some other, general health lifestyle changes. Next slide. So as you prepare to conceive, a healthy lifestyle is really important. There's not necessarily any one specific lifestyle change that is like the magic answer for conceiving, except for maybe quitting smoking. That has a big impact. But these are all general things that we can do to prepare our bodies for a healthy pregnancy. Exercise is very important, maintaining a healthy lifestyle, active lifestyle, healthy BMI. Stress management techniques, trying to eliminate or reduce stress in our lives, eating well, healthy diet, lots of green leafy vegetables, whole grains, lean proteins, healthy fats. Again, none of those is a magical superfood, but we recommend that for everybody because those are recommendations during pregnancy as well. Smoking is a big one. Smoking is one that does significantly impact fertility for males and females. Quitting smoking has been shown to improve sperm quality, egg quality. So that's a big lifestyle factor. And that's, one that we recommend if you're, planning to build your family. Reducing or quitting alcohol use, that is also a factor as well. Another question that we get all the time is questions about supplements. Is there a supplement I should be taking? Is there a nutrient that will help me to conceive? And the research is not really conclusive on that. And opinions from providers will vary quite a bit on that as well. There are some who really endorse taking, a whole cocktail of nutrients or vitamins. And there are others that are like, that really isn't going to make a difference. Make sure to just take your prenatal vitamin. So talk to your doctor, because based on your health history, there are certain nutrients like CoQ10 or in some cases DHEA that may benefit you. But we don't just really, recommend that without talking to your provider about that first. Another important thing for preconception, we talked a little bit about the cycle length. That's an important thing that you can discuss with your provider at the preconception appointment that can help shed light on, any health conditions that may need to be addressed before trying to conceive. So a preconception is an appointment with your regular GYN provider, where you can review your health history, family history, menstrual history, and address any, issues that may become a problem if you're trying to conceive. So knowing your cycle length and tracking that, and just knowing if your cycles are regular, irregular, long, short, that really helps your provider to, determine whether you need to talk about doing interventions sooner rather than later. On average, for healthy couples under the age of 35, it's normal for it to take up to 12 months to conceive. And that doesn't mean that anything's wrong if it takes up to 12 months. Fertility is a little bit of a numbers game. So sometimes just getting the stars aligned and having it all work out, it can take up to 12 months, and that's considered normal. Infertility diagnosis is made after the 12-month mark for couples under 35. If you're 35 to 45, then we recommend giving it up to 6 months of trying on your own before seeking help. And then if you're over 40, then the recommendation is to seek help a little bit earlier. But at your preconception appointment, this is a really good opportunity to talk to your doctor if you have irregular periods, if you suspect that you may have conditions like PCOS or endometriosis, which Dr. Elguero is going to talk about later. That kind of helps to determine the urgency of interventions and whether it's reasonable to try on your own and do the cycle tracking. we talked a little bit about this, but with the preconception appointment, if you have fertility concerns, if people in your family have had a hard time conceiving, or if your cycles have been irregular, or if you're not sure, if you've been on birth control your entire reproductive life and you have no idea if your periods are regular or irregular, it's important to kind of share that with your doctor, and again, determine what interventions are appropriate. In some cases, for couples under 35, even if it hasn't been 12 months yet, in some cases it's recommended to do some baseline testing, which again, we'll talk a little bit more about that later, day 3 labs, AMH. It's reasonable to do that testing earlier rather than later if you have some things in your history that may be red flags that you may have some difficulty conceiving. And then I'm going to turn it over to Dr. Elguero, who's going to talk a little bit more about our cycles.
Thanks, Christine. So in terms of tracking our cycle, it's important to understand that the cycle has many different phases. And so our menses, or our first day when our cycle starts, is not just when we have spotting. We usually want to think of day 1 as first day of full flow, that heavy flow. And it can be normal for many women to have spotting, of course, before full flow. After we complete menses, and that can range from, let's say, anywhere from, 4 to 5 days, and it's not abnormal for it to be a little shorter, a little longer, we then move into what we call the growth phase. It can be labeled the proliferative phase or the follicular phase. And essentially, this is when we have our pool of follicles. Follicles are fluid-filled sacs that contain our eggs, that are under the guidance or the stimulation of FSH hormone, which is secreted from an area in our brain called the pituitary. And so under the direction of that hormone, one follicle, and only one, is chosen, and that's destined to be our dominant follicle. That follicle will then suppress other follicles from coming forward. And within that dominant follicle is the egg that is also maturing. So that growth phase takes roughly 2 weeks. So mid-cycles, typically day 14 for someone with a 28-day cycle. And that's when, under now the guidance of a second hormone called luteinizing hormone, or LH, that's also released from the same region of the brain, the pituitary, that's when the egg actually mechanically ruptures from the follicle. So it's released from the follicle and picked up by our fallopian tube, either the left or right, of course, and that's where fertilization occurs, within the fallopian tube. Thereafter, that ruptured follicle has a new name. It's called a corpus luteum. And the sole purpose of the corpus luteum is simply to make progesterone, because progesterone is vital for implantation to occur. And that's what the luteal phase is. We're prepping or preparing for implantation or pregnancy. The luteal phase is of similar length. It's roughly 2 weeks in duration. And again, that's when we have a thick lining or thick cushion, and we're awaiting implantation. Then we have either 2 tracks. Either the patient is going to be pregnant and not have her menses, or unfortunately, she will achieve menses, and then the cycle repeats itself. We're back to day 1. It is important just to comment briefly that one can be pregnant and have bleeding. So especially for patients that are within fertility treatment, we never want to make the assumption that we're not pregnant or that a treatment has failed if we've had bleeding. Next slide, please. So how long does this take? Earlier, Christine had alluded to the length of time, and she alluded to probability sometimes being an important piece. And she had alluded to it taking sometimes up to a year for younger patients that are under 35. And when we're over 35, it certainly can take longer because our eggs are longer, but generally after 6 months, we do want to seek evaluation. The chances of conceiving, of course, are going to be higher around the fertile window, which is around the time of ovulation. So when we think about that LH surge that I had just mentioned, from the time that LH is secreted to when we actually rupture our egg from the follicle, that window of time is typically up to 36 hours. So there is a very sensitive fertile window, within our cycle where our chances for conceiving are higher. And of course, there's many ways to track, be it an app, be it a manual calendar or be it an ovulation predictor kit. These kits are readily available from local stores and drugstores. And what we do, of course, is at specific time periods during our cycle, typically close to mid-cycle, we pee on these sticks. And what we're detecting is the luteinizing hormone in the urine. So many ways to track that fertile window or period. Under the age of 35, up to 86% of patients are pregnant by the 1-year mark. Between ages 35 and 40, that percentage goes down to the low 80s. And then as we get beyond 40, the data is variable, but essentially it does become a lot harder to conceive because of aging eggs. So what I mean by that is after 40, not only does our quantity of eggs go down, but our quality of eggs also declines. So as Christine mentioned, it's important that if we're around that age, in many instances, the OBGYN providers are referring directly to fertility doctors. Next slide. I'll pass this back to you, Christine.
Great. So we talked a little bit about cycle tracking and the average cycle length. There's a few other things that we can do to help us narrow down our fertile window. A couple different methods that are commonly used are basal body temperature, or BBT. This is where you use a thermometer that has 2 decimal points after the period, or 2 numbers after the decimal point. And what most people will see is a subtle change in temperature throughout their cycle. Typically, just before you ovulate, you'll see a slight drop in your temperature. And then after ovulation, that progesterone causes a thermal shift, and your basal body temperature will remain slightly elevated throughout the luteal phase. If you become pregnant, it usually remains elevated. And if you do not conceive that cycle, you will usually see a slight drop again before your period starts. We had a question in the chat about spotting a few days leading up to the period. That is very common. A lot of people will confuse that spotting for their actual period, and it's not. Your day 1, cycle day 1, is considered your full flow. Like the first day, you really have an active bleed. That's like annoying spotting where you need a panty liner, but you don't really, need a full pad or tampon. That is considered part of your luteal phase. And we see that more with age. Sometimes people will experience a bit more spotting. Dr. Elguero mentioned the importance of progesterone to support pregnancy. Some people with a very short luteal phase are given progesterone suppositories or supplements, not routinely, but in some cases that's appropriate. So knowing when you ovulate in the cycle, what the length of your luteal phase is, when you ovulate exactly, that's extremely helpful for you and your doctor to talk about. Other tracking methods include cervical mucus changes. So many people notice that around the fertile window, just before or during ovulation, cervical mucus will take on a thready, thin, almost egg white consistency. The other thing that people use often is the OPKs, or ovulation predictor kits, that were mentioned. I do want to mention with the OPKs, people who have really irregular cycles, or who have what we call oligomenorrhea, where they don't have a cycle or they don't have a period very often, or it's unpredictable, sometimes will have a harder time with the OPKs, or they may not be quite as accurate, because it really helps if you kind of have an idea of when you're about to ovulate so that you can start using them and detect that LH surge. So for people with irregular cycles, sometimes the temping is a good low-tech method, and keeping track of your cervical mucus. So all these clues together can really help you pinpoint when ovulation is occurring and when you are most fertile. Next slide. So Ovia has 3 different apps. We have a fertility, pregnancy, and parenting app, and we really provide support across the lifespan. We also provide menopause support, mental health support. Even though our fertility app is considered a cycle tracking app, we provide a lot of support for people who are building their families other ways. If you're a single parent, or if you're a gay couple, then obviously no amount of cycle tracking is going to help you conceive, but we still provide resources, information, support for our users who are building their families in other ways. So these are some examples of common questions that we get on the app. So we have a free version of the app that everyone can access, where it has the tools like the cycle tracking, or in our pregnancy app, we have a lot of really good information there. People who have Ovia as a health benefit through their employer also have access to Ovia coaching. And these are some examples of questions that we commonly get with the coaching. You can ask a question through the app, and somebody like me or one of my colleagues responds through the app right away. We don't give medical advice, that's specifically, for you to discuss with your doctor, but we give a lot of general information and support. So questions like this, my pregnancy test is negative. Why is my period late? I have PCOS. How can I maximize my chances of getting pregnant? Can I do insemination at home? Do I have to get regular cervical exams? When do I need mammograms? A lot of this general health support, we can respond right through the app and provide you with more information. So we're a really, really good resource for just general health knowledge. All right. And I'm going to turn it back over to Dr. Elguero. We're going to talk a little bit about different pathways to conceiving.
Okay, great. Take the next slide, please. Great. So in the next few slides, we really want to talk about some, pertinent fertility information, just because there are a lot of myths out there. So we do want to debunk some of those myths and give you some information that would hopefully be very useful. Next slide. So what is infertility? It is a disease process that can be attributed to either the male or female partner that prevents conception or may delay conception. And that can be broken down into many different causes, whether they're female causes, male causes, a combination of causes, and sometimes it's simply undefined, or we use the term idiopathic. When we look at female causes, and we're going to talk about that shortly, that can involve disorders with ovulation, disorders with our anatomy. It could involve disorders with sperm production. Sometimes with male infertility, it's not so much with production. There could be an obstruction happening locally at the level of the testes. And sometimes it's a simple thing we discern on history. Sometimes the male partner is using testosterone, and that's something that can inhibit sperm production. In this country, in the US, 1 in 6 patients with no prior births are unable to get pregnant after 1 year of trying. And I think, understanding the breakdown, racial, ethnic, geographical differences are not really quite understood. Next slide. So honing in on female infertility, if we start first with tubal factors, it's important to understand that the tubes are vital for transporting our gametes. So I like to think of the tubes as tunnels that are transporting the eggs and sperm. And tubal factor infertility can occur when those tubes, a single tube or both tubes, are blocked or occluded. And when that happens, certainly the egg and sperm cannot meet and we have infertility. And this accounts for up to 1/3 of female factors. Why would our tubes be blocked? Sometimes it's congenital, so we're born that way and we don't know why. And in other times it's induced, meaning it's caused by an extrinsic factor, such as a sexually transmitted infection. Perhaps we didn't know we had that 5 years ago. Perhaps we didn't have symptoms. Pelvic inflammatory disease, and endometriosis. So you can see there's a common theme of inflammation. And because the lumen of the fallopian tube is so small, it doesn't take much inflammation to actually cause a stricture or occlusion in the tube. And how would a patient know that they have tubal factor or blockage? There are tests on the market that OBGYN providers can do, fertility doctors can do, FemView, HSG, which involves dye being insufflated through the fallopian tubes, and also laparoscopy, which we're also going to talk about. There can be uterine and cervical factors, which actually prevent the embryo from implanting, or perhaps the embryo implants and a miscarriage is induced. That can be caused by fibroids, for example, congenital abnormalities, such as having a duplicated uterus or having a smaller uterus. Sometimes we're just born with an abnormal uterus. And sometimes even narrowing of a cervix. We use the term stenosis. That can impede the sperm from traveling up the reproductive tract. And finally, there can be ovulation disorders, which actually account for a large percentage of female infertility, approximately 40%. And that can be caused by many, many different factors and conditions. One of the most common being polycystic ovarian syndrome, or PCOS, which we're going to talk about. Perimenopause, meaning as we get close to menopause, our ovaries, sometimes I like to think of it as they get fatigued. We're not always ovulating every month. Sometimes ovulation is more sparse. Strenuous exercise can affect our ovulation. And why would that happen? Sometimes it actually causes our hypothalamus and pituitary, these are regions in our brain, to become quiet or sleepy. And when that happens, there's very minimal stimulation or absent stimulation to our ovaries. Our thyroid gland, located here, is also very critical to successful ovulation. And then finally, an elevated prolactin hormone, which is involved with milk production from the breast tissue, that can interfere with ovulation, and even obesity. So you can see there's quite a number of factors that, your doctor, provider, OBGYN, fertility specialist can help, uncover through testing. Next slide. So what is PCOS? It is a common, many times underdiagnosed cause of infertility or subfertility. It's a condition whereby our ovaries are producing an abnormal amount, a higher amount of androgens, which are male sex hormones. And as a result of that abnormal local ovarian environment, the follicles don't always grow or mature properly. There can be dysregulation or dysfunction. And also at the level of the ovary, there can be a higher level of insulin. So that abnormal environment, or milieu as we call it, can affect our ovulation. There are many symptoms of PCOS: absent periods, irregular periods, sometimes increased hair growth in male distribution areas like the sideburn area, the upper lip, the chin, oily skin, acne, thinning, or alopecia. And this condition is also associated with many other conditions: insulin resistance, metabolic syndrome, a higher risk of cardiovascular disease, and even uterine cancer. So this is a very important condition to discuss with your provider, because as you can see, the presentation can be very broad, and of course testing and treatment for PCOS can be quite broad, and this is obviously very much individualized to that patient who has PCOS. Approximately 5 to 10% of women between ages 15 and 44 can have PCOS. Next slide. What about endometriosis? So completely different condition from PCOS. And I didn't mention before, we do think PCOS is genetic, and we do think the same with endometriosis. However, interestingly, we've not identified the gene responsible for both. What is endometriosis? So it is a condition whereby our endometrial lining is extruded through our fallopian tubes and it lands in our pelvis. Now, every woman has some degree of what we call retrograde menstruation, meaning our lining and our blood flow is not just, coming through our vagina, but a small proportion is actually, exiting through our fallopian tubes. It's going backwards. So every woman has some degree of that. The difference between someone having endometriosis and not having endometriosis is that those who have endometriosis are more likely for that tissue to stick or to implant. And it can implant anywhere: on the bowel, on the bladder, the pelvic sidewall, or the ovaries. And what does that do? It can cause significant pain at the time of menses, pain during intercourse. There can be GI symptoms like diarrhea or constipation, heavy menses, irregular menses. We had someone in the chat ask about spotting. Spotting can be caused by endometriosis. So how do you get diagnosed? Is it an easy diagnosis, a hard diagnosis? Diagnosis can sometimes be presumptive just through talking to a patient, meaning the clinical history, but the gold standard is truly through laparoscopy, That is a surgery that is done by OBGYN doctors, whereby a telescope or a laparoscope is inserted through the umbilicus, and we blow up the belly with CO2 gas, and we're able to visualize our organs. And if we see the lesions, which can manifest in different ways, they can be white, brown, black lesions, sometimes very small and difficult to appreciate unless they're under high magnification. And we actually biopsy these lesions. And then through histopathology, we're able to formally diagnose endometriosis. Who should you see if you think you have it? I mean, I would say your OBGYN provider. Obviously, if you have infertility, this is going to be discussed with your fertility doctor. And what can you do if you've been diagnosed? Or you've had it, for many years, maybe it's chronic. I do think you should be speaking to your OBGYN provider about your goals for fertility. Why? Because endometriosis is associated with infertility. It doesn't always cause it, but there is a clear association there. So depending on your age, depending on your goals, an OBGYN provider may refer you at an earlier stage to a fertility provider. And in other instances, it may just be treating the endometriosis with hormone therapy, such as birth control pills. Finally, there is another condition called adenomyosis, which can be very similar to endometriosis in terms of presentation. I think the difference is adenomyosis is more common in older women, and sometimes we can diagnose it through imaging, or I should say a presumptive diagnosis through imaging, because the uterus looks somewhat bulky. And it's when the endometrial lining is actually growing into the muscle of the uterus, so it's not going outside the uterus into the pelvis like endometriosis, but the lining is actually growing into the muscle. Next slide. So what are the treatment approaches that are typically discussed? We essentially have two different pathways: IVF, IUI. IVF is essentially when we stimulate ovaries, we extract eggs, and we combine eggs and sperm outside of the body in vitro, and we're able to create embryos, and then through a selection process, typically a single embryo is placed back into the uterine cavity. That is very different from IUI, which stands for intrauterine insemination, which is a process of essentially inserting sperm. So we load a catheter with sperm, and we simply pass that catheter through the cervical opening. And by doing so, we're able to get a larger amount or concentration of sperm, not only higher up in the cavity, but closer to the egg. And we're able to orchestrate the timing through tracking, referring to ovulation, that is. Next slide, please. So what is ART? ART stands for Assisted Reproductive Technology. So it's a very broad umbrella. And that includes all fertility treatments whereby either eggs are being handled in the laboratory or embryos are being handled. So it can involve egg freezing, it can involve IVF. In terms of looking at IVF success, that's going to really vary depending on the age of the patient. The egg reserve or the ovarian reserve is going to depend on the presence of chronic medical conditions, and also the cause of the infertility. So for example, if someone is 40, many times we're going to guide them towards IVF because of their age. If someone has blocked fallopian tubes, we're going to guide them towards IVF because the eggs and sperm cannot meet naturally. And similarly, in thinking of IUI therapy that we just discussed, let's say we have a single woman who's using donor sperm. She may not need IVF if she's young and fertile. We would simply just board the sperm into the uterus and do simple therapy in the form of, we use the term TDI, therapeutic donor insemination. Briefly, IVF is a lengthy conversation, but just briefly, it involves many steps. The first step is stimulating the ovaries for a roughly 2-week duration using predominantly FSH hormone, which I had mentioned previously. So the FSH that we secrete from our pituitary is available commercially in recombinant form. So patients are taught how to self-administer FSH. So that's roughly a 2-week period to stimulate the ovaries, and then we monitor the ovaries very carefully with ultrasound and blood work. We then carefully harvest or retrieve the eggs using in-office procedure that does require sedation. It's a short procedure. It usually takes about 15-20 minutes, and the risk is relatively low for there to be a complication, which is obviously very positive. It would be very difficult if the complication rate was very high. And then once the eggs are extracted, they're combined with the sperm through different methods, either through injecting sperm or mixing. And then ultimately, IVF is a tool for embryo selection. So we're able to select a competent embryo either through studying its structure or through DNA testing. And the goal is then to take that competent embryo, typically a single embryo, place it back into the uterus, and then we await pregnancy. Next slide.
Right. I wanted to take a moment to talk a little bit about supporting mental health while you're trying to conceive. The challenges around infertility are really unique, and it can cause a great deal of stress, anxiety, depression, strain on relationships. And a lot of people going through infertility find that they feel very lonely and very alone, when in fact, as we talked about earlier, infertility is extremely common. We always say it's the club that nobody wants to be a part of. There's still a bit of a stigma around infertility, so many people don't talk about it, don't feel comfortable. A lot of people find that when they open up and they do share a little bit about it, that they find other people that they know who are going through similar experiences. It may be helpful to discuss a lot of what you're going through with a mental health provider. One thing Ovia does is we help to put you in contact with resources or with providers, many of whom specialize in IVF. A good resource also is your fertility clinic. So if you're currently working with a fertility practice, many of them have either in-house or people they refer to that are licensed healthcare providers who specialize specifically in the unique challenges of infertility. We also recommend self-care. It's really important, when you're going through this extremely stressful process, to take some time to do something that supports your mental health. For some people, that means yoga. Some people, that means travel or distraction, or just having a support system, either a partner, friend, mother, colleague, somebody that you trust, who you can, share a little bit about, as much as you're comfortable, what you're going through, and can support you. Online communities can also be a source of support. We talked a little bit more earlier about the misinformation that's out there. And unfortunately, chat rooms, forums, they can be a great source of misinformation, but they can also be a source of support. Sometimes hearing anecdotes from people who have gone through similar things or people's experiences can be really helpful, especially if you're not comfortable sharing with people in your personal life. Sometimes having that anonymous source of support can help as well. Next slide. It's difficult to talk about infertility without also talking about pregnancy loss. Many people struggle with getting pregnant. Other people struggle with staying pregnant, or both. There are many factors at play in terms of pregnancy loss. Chromosomal anomalies are a common cause of miscarriage, uterine factor issues, immune issues. These can all come into it at play. Obviously, pregnancy loss is deeply distressing, and everybody has a different experience with that. Some people feel dismissed when they're grieving a chemical pregnancy or a very early pregnancy loss. And, people say, oh, that's fine. It was nothing. You barely knew you were pregnant and you'll have another chance later on. Well, you may not feel that way when you're going through it yourself. So Ovia provides a lot of resources. There's some that are listed here that are really good that we refer to regularly for just dealing with the loss and the grief associated around infertility and pregnancy loss.
Before I get into some other resources for the pathways to parenthood, there were some questions that came up throughout that I think are relevant to the conversation. So maybe one of you guys could answer, what are some tests that could diagnose PCOS, or how that's identified with your provider?
Yeah, so there's a clear way to diagnose PCOS. One test is really history. So if a patient gives you a chronic history of irregularity, that's part of the diagnostic criteria. A second is actually blood testing. So we check the male hormones. We use the word androgens. And if those hormones are elevated, that is also part of the diagnostic criteria. And finally, ultrasound. Transvaginal ultrasound is part of the testing modality for PCOS, whereby we're looking for a very specific appearance of the ovaries. Many times you read about a string of pearls, like the follicles are draped in high number around the periphery. So certainly blood work, history, and ultrasound are part of the diagnostic criteria for anyone who thinks they may have PCOS. And one final thing about that, it's important to know it's a diagnosis of exclusion. So if we do that testing and we check the boxes and say, yes, you meet criteria, you have to exclude other causes. And we had that up on a previous slide, thyroid, prolactin, right? Making sure there's nothing else, even pregnancy, right, that could be causing menstrual irregularity.
Great, thank you.
In terms of treatment options for PCOS, it kind of depends on what your immediate plans are. So if you have PCOS, but you don't plan to conceive anytime in the near future, then it may make sense to control it with Depo or oral contraceptive pills. Metformin is a common treatment as well. We talked about the insulin resistance aspect of PCOS. Lifestyle changes, healthy weight, diet, that sort of thing can help too. But when you reach a point where you're actively trying to conceive with PCOS, the treatment options change. Sometimes, depending on the severity of the symptoms, it's reasonable, in addition to the lifestyle changes, to consider ovulation induction with medications like letrozole or sometimes Clomid, or more commonly letrozole, to see if you can induce ovulation and still conceive, somewhat on your own or with timed intercourse before considering the other options like IUI and IVF.
We also had a question around antidepressants and what are safe to take during fertility treatments. I think we can say definitely have a discussion with your providers based on your own health history. But any other thoughts that you two may have?
Yeah, I do think it's important that risks and benefits are carefully weighed. I think sometimes there's a gestalt, oh no, you're on a medicine, stop the medicine. But we have to think about the importance of having a mom that's healthy mentally for the 9 months of pregnancy and beyond, right? Could be well over a year, right? Or 18 months. And so I think that this does need to be a very unique counseling session with a prescriber, because that is going to be the provider that knows the patient from a depression standpoint or anxiety standpoint. And so many times we make the decision for our patients to remain on antidepressant therapy throughout fertility treatment and beyond, throughout pregnancy, because we feel the benefit outweighs the risk. And finally, there are some drugs that have been around for a long time whereby there's a lot of safety data. So many times the provider might just say, we're going to keep you on it, but we're going to switch to a drug that has more safety data. So it really needs to be a discussion and not a reflexive, oh, you're coming off the medicine.
Sorry, I'm getting through some of the questions here.
I know we had a very specific question about age and menopause, and we won't go into too much detail on specifics. We kind of want to keep this broad, but I did want to mention we didn't go into a whole lot of it with this webinar, but for patients of advanced maternal age, even though, as we saw in the previous slides, that the success rates for IVF over 40 are very low using own egg, donor egg treatments are very successful. So the age of the uterus is much less important than the age of the egg or the age of the embryo. So oftentimes donor treatments can be considered and are quite successful. So that's another consideration.
Thank you. There was a question around just obtaining sperm for someone who is going through IUI and what that process and timeline looks like.
Sperm can be obtained through different methods. I mean, some patients are interested in home inseminations that does not require working with a fertility practice. They're able to order sperm directly from the bank and have it delivered to their home. I think even when a patient is doing home insemination, obviously there is important prenatal testing that's many times done. Christine alluded to just important care beforehand, like folic acid. But sometimes our doctors are interested in even checking basic things like our immunization status, checking our thyroid, our blood count, before pursuing treatment. But it can be obtained directly from the bank for home use. And then there are some patients for varying reasons. Let's say a patient has PCOS and needs medication and monitoring. That patient may elect to, order sperm through a clinic. And so in that fashion, the sperm is obviously sent to the clinic, and then we're involved with the actual treatment, which is the IUI, or alternatively, it could be IVF through the use of donor sperm.
And we had a question about ejaculatory factors. There's a process called a TTC, where a urologist or sometimes the fertility specialist can collect sperm through a surgical procedure. So with sexual dysfunction or other blockages in the male reproductive tract where the sperm isn't exiting the way that it's supposed to, that is an option. And IVF with ICSI can be done in the lab. In terms of sperm banks, the great thing about this day and age in family building is that you can obtain donor egg, donor sperm from across the country, and in some cases even internationally. So if your IVF or if your fertility center works with a sperm bank, but it has a limited donor pool or limited ethnic backgrounds or whatnot, you can look at sperm banks across the country and generally find what you're looking for, and sperm and frozen eggs can be shipped to your fertility clinic. So a lot of options out there. You're not tied to the donor pool locally where you are, which is great.
Great. There was one other question about tracking your basal body temperature, and if it does increase, I think the luteal phase, and is at least 12 days, does that mean your progesterone levels are probably okay?
So a better way to know for sure would be, and Dr. Elguero, you may want to chime in on this as well, is to do a day 21 progesterone check. So the basal body temperature does help. So if it remains elevated, that's a pretty good indicator that there's not a luteal phase defect if your luteal phase is 12 days. But if you're not sure if you're ovulating, or you're not sure if you're ovulating when you think you're ovulating, some providers will order day 21 labs to do a progesterone check.
Yeah, I agree with that, Christine. I think that this concept of luteal phase defect is a difficult one because there's no way to truly diagnose it, as you know. And the reason why is because you could measure a progesterone level 20 times and you're going to get a different progesterone level every single time because it's pulsatile. It waxes and wanes and goes up and down. So what's useful is what you mentioned, mid-luteal phase, approximately day 21, if a progesterone level is greater than 3 nanograms per ml, that does reliably indicate ovulation.
Yeah, and that is important to note about the fluctuating progesterone levels too. A lot of times in early pregnancy, we'll check a HCG and a progesterone level, and we get a lot of users like writing in panic saying, "Oh my gosh, my progesterone is low. Is this not a viable pregnancy?" And the serum levels fluctuate so much that it doesn't mean anything if it's a little on the low side. So, take the progesterone level with a grain of salt is what I always advise.
And I think there was a question about a patient who outlines that she was diagnosed with PCOS, and as doctors or providers, how do we choose between Clomid and letrozole? So Christine had mentioned these two drugs earlier, that they are drugs that are used for ovulation induction. If you look at more modern data, newer published data, it seems that letrozole does have a higher live birth rate than Clomid. And that's why it tends to be kind of the first line of medications that's chosen for ovulation induction. And also, the side effect profile can be a little bit more gentle than Clomid, if you agree, Christine. And then also, there tends to be this notion that letrozole might have a lower twinning rate or higher order multiple gestation rate, though more recent studies have shown that that rate is comparable. But I think largely the first line drug would be letrozole simply because of the higher live birth rate. But we do use them interchangeably. And, many times with PCOS, we can see resistance with one drug and then the other drug works more effectively. So that's where the individualized care comes in, monitoring the patient and understanding how they are responding to that respective drug and to that respective dose.
Yeah, agreed. And I do see in some cases the decision isn't necessarily clinical, but it's what's on your formulary. So, in some cases I see starting with Clomid because that's what's covered by your insurance. But then, if there's a treatment failure or whatnot, then letrozole is considered next. Although I do find that usually, letrozole is the preferred ovulation induction medication for PCOS specifically.
And there was another question around ovulation induction drug, and would it work even if you may not be ovulating on your own?
So I can start. So sometimes ovulation induction drugs don't work or you need a higher dose. So, if you're not ovulating on your own, sometimes what they'll do is they'll give you a medication like Provera or something to trigger a bleed, and then we'll start the ovulation induction. So that, after your bleed or during on day 5, you'll start your letrozole. Sometimes first couple rounds aren't successful, and so they'll increase the doses, and sometimes that helps. Not always. Usually I see it work, and usually we do see it successfully induce ovulation, but that is not true for everyone. And in some case, other methods need to be considered.
Yeah, I agree. I mean, I think if you look at the literature, about 80% of the time, patients are responding to these oral medications. And then another thing we didn't mention is when we're using these drugs and monitoring the patient with ultrasound, that's one piece of treatment, helping to grow and support the follicle. But in most cases with PCOS, we are using HCG. We're using pregnancy hormone to actually physically induce ovulation. So we have to remember, kind of going back to the phases, there's growing the follicle and releasing the egg. So it's almost a 2-part treatment: oral therapy and then the HCG trigger.
Great. And one last question before we move on. Just how many IUIs are usually recommended?
Yeah, so it's not so much a rigid fixed number. I think, again, it depends on the age of the patient. Do they have infertility or not? What if it's a single woman using donor sperm? So it's really important to kind of hone in on why they're doing IUI. And again, age is always such a crucial factor when it comes to understanding how much treatment we do and really understanding how much time we have for the reproductive window. But I would say in general, 3 to 6 cycles. And a lot of that comes from just understanding probability. And Christine had mentioned earlier, like, this is somewhat of a numbers game. It is true. So we don't always expect the very first IUI to work. I mean, technically, the 3rd cycle is thought to be highest probability. So there is a curve. And so the more you do up to a certain point, the probability does go up. So 3 to 6, I would say on average. And obviously that can shift, again, depending on age, and other factors.
And I would say it's a bit of a financial decision at times too. Sometimes there's not always an obvious answer. And it may make sense financially to say, well, IUIs are significantly less expensive, a little more affordable. We're going to try this for longer before moving on to more invasive or more expensive options. So sometimes it's kind of a combination of clinical and financial and logistical, depending on what your goals are and how quickly you're trying to get a baby in your arms.
Yeah, and I think emotions too. I always say there's financial considerations, science, and how we feel. I mean, sometimes patients are just not ready, to move beyond IUI, and that's okay. And that's where having, good communication with your doctor is key.
Well, thank you both. I think, as always, make sure that you're having the conversations with your providers to see what makes sense for you and also to check your health plan or your employer benefits to see what's covered. All of those are unique to you and your journey, and specific to your health history and your coverage. I just want to talk briefly about some of the other support that is available if you have a different pathway to parenting, either through surrogacy or adoption. Ovia Health has lots of education within our app around, starting that process, what questions to ask, what do I expect, what communities can I build, what resources do I have around me, both from a clinical education programming within our apps, and then also our care team, which Christine is part of, and I'll go through that on the next slide here. They also have lived experience within these journeys. So if that is part of your family building journey, we can certainly support that as well. And if you do have Ovia through either your health plan, CDPHP, or maybe directly with your employer, you may have access to our wonderful care team. So we'll talk about how to enroll here in a second, but our care team has a variety of clinical expertise and is available in app 365 days of the year for 12 hours a day, just text messaging, or you can schedule a telephonic call. I know that I've used them quite a bit for various things with my own health and my pregnancies. So they're really great from both a clinical and lived experience. So all the wonderful things that we talked about today, how do you connect to some resources and benefits that you may have? If you are interested in downloading the Ovia app, I'll leave this on here for a second, but you can go to the QR code here or go to the App Store to download which app is right for you. So either Ovia, Ovia Pregnancy, or Ovia Parenting. If you are a CDPHP member, you please select I have the benefit through or have an Ovia Health as a benefit, and then enter CDPHP, and that'll unlock all the wonderful resources through CDPHP. If you are interested in connecting more with Boston IVF, you can contact Emily, who is a physician liaison, and you can see her number here on the screen, or you can call the scheduling team at their number to schedule your initial consultation. And I'm going to go to the next screen here to give you a little bit more information on all the wonderful services that Boston IVF offers. So you can see, the consultations, initial testing, fertility treatments, genetic testing, egg freezing, and so much more. So if you have any questions, you can also go to their website here, bivfnewyork.com. I'll go back to the previous slide so you guys can see that as well. That is all that we had for you guys today. I did see one other question that came through in our last couple of minutes before I give our closing remarks. One was just around wondering where to start with preconception. And hopefully that answered the question there. You can certainly start with Boston IVF. That would be wonderful. They're a great resource. And we just really appreciate Dr. Elguero, all of your education today, along with you, Christine. I think most people learned quite a bit. So I think we've answered most of the questions. As a reminder, don't forget that when you close out today, there will be a post-evaluation survey that will pop up. We would love to hear your feedback so that we can learn and make these better for you in the future. And also today's seminar will be recorded and emailed to you as well. So thank you again for joining. We really appreciate your time and your engagement, and thank you for all of the questions.